Welcome to Quick Hits, the podcast where we explore the cutting edge of healthcare technology. Today, we're thrilled to have Dr. Kumah-Crystal join us. Dr. Ya is a Health IT Clinical Director and Associate Professor of Biomedical Informatics at Vanderbilt University Medical Center. Dr. Ya's work focuses on enhancing communication with electronic health records through innovative approaches like voice technology and generative AI. As the project lead for the Vanderbilt EHR voice assistant, Viva, she's integrating voice user interfaces into clinical workflows, aiming to make interactions with EHRs more intuitive for healthcare providers. Beyond her research, Dr. Ya is actively involved in patient care, supervising fellows and residents, and managing her own pediatric endocrinology clinic. Dr. Ya also played a pivotal role during the COVID-19 pandemic as the clinical director in health IT for telemedicine at Vanderbilt, deploying telehealth solutions to ensure continuity of care. In this episode, we'll get into Dr. Ya's insights on the evolving role of AI and voice technology in healthcare and how these innovations are transforming patient care.
To another episode of Quick Hits. I'm your host, Ken Booth, joined as always by my co-host, Tyler Smith. Tyler, how are you?
Great, Ken. Excited to be here.
Yeah, absolutely. You know, we always have excellent guests on deck, and this episode is no different. We're talking to Dr. Ya, as she's affectionately known by her patients, Dr. Ya Kumah-Crystal. She's the Health IT Clinical Director and Associate Professor of Biomedical Informatics at VUMC. Thank you so much for joining us, Dr. Ya.
Thanks for having me. I'm psyched to be here.
Yeah, good. You know, we love to talk to leaders like yourself, especially because you have a unique background, which we think is so important in the space, which is you're a physician and a healthcare IT leader. So if you could kind of give us a little bit about your background and how you got to where you are today, and then we'll kind of continue the conversation from there.
Sure thing. I think I got into health IT by virtue of having dabbled a bit in computer science in undergrad. I was a biophysics major and we did some basic Python programming. And then I entered med school in the era where EHRs were becoming a thing and people were transitioning from paper to digital. So I was kind of at the forefront when all that was going on. And having known a little bit about how computers worked, seeing the first iteration of the implementation, I was like, oh no, guys, hold on. Let's back this train up a little bit and think through about how we're making this work so it's actually easy to use. We're not having to repeat what we're typing in over and over again. And honestly, I think I just complained enough and annoyed enough people. They're like, you need to go talk to our people in health IT. And they said, sounds like you have a lot of complaints. Why don't you work on fixing the problem with us?
That's awesome. You know, so many people in your position at that particular moment in time, and I think Tyler and I have both worked with individuals who kind of went the opposite way. They didn't want to adopt the new technology, but it seemed like you saw the need for changes. So what inspired you then to just really bridge the gap? Like what is it, just because you had that little bit of background in computer science, or was there more to it that helped you see the potential?
I've always been kind of a tinkerer, like a maker, and I just see opportunities where they exist. Bill Stead, who's one of my, heroes here in the informatics space, he has this saying about like seeing systems that don't exist. And it just resonates with me so much that I can map out in my head. I'm like, I feel like I know exactly how to, or at least a good way to address this problem if we did A, B, and C. And just instantiating that and seeing that coming to life and seeing it actually improve the way that we're delivering care is so satisfying that I can't help but work to fix things.
Excellent. Good. That's a great mindset to have. And that would explain just kind of the list of accomplishments that I see from you, like specifically like voice technology in healthcare. I think that's a great avenue. Your work includes projects like Vanderbilt's adoption of voice assistants. How did you see, or how do you see like voice tech kind of where it's come? And then how do you see that changing technology or changing healthcare in the future?
I'm so excited about where voice tech is going. I'm kind of a, yapper. I love to talk. I love thinking out loud. I ideate out loud. My husband, bless him, he's always like, okay, I think we get it now. So just the concept of being able to think aloud and have something materialize from your thoughts has been an interesting concept to me. I think the connection between having voice technology outside of the science fiction that we've always seen and, Star Trek and even Star Wars and all the star things, and actually something in the EHR, ironically, first materialized, it was around like 2011 or so, with some of the first Siri commercials where I think it was like Zoe Deschanel or something. She was like, "Hey Siri, what's the weather?" and I was like, why can't I just do that with my computer and ask about things about my patients? And it just really clicked for me there. And I was like, this is a thing we need to be doing yesterday. Um, and I spoke to my chair, Kevin Johnson, who is just an amazing visionary in this space. And he was like, yeah, a lot of people have given that a lot of thought. And maybe we're in a place where some of the technology is close enough to us to get there. And we worked on building out some prototypes where you could ask questions with natural language and get some information back. And I mean, back then when I was like, this is the future. But where we are now, I mean, with 2021 and, the breakout of transformer models and LLMs and everything that's emerging, holy cow, the realness of what is meant to come next. And ironically, just the series of yesterday and the potential they still have, is pretty exciting.
It's so interesting to hear that 2011 is when you actually started getting interested in voice tech. Because I remember you were one of the OGs in like the mid 2010s that was talking about voice tech. Way before our present day, where now you have a bridge and Dax honestly stealing the show at a lot of these conferences. And curious, Dr. Yah, how you stuck with it through kind of a winter of voice tech until it seems to be almost like a renaissance right now.
I love it. Well, I guess I always had my voice assistants to keep me company.
There you
I
go.
like to joke that I literally have more like Alexas than people in my house.
Okay.
And just thinking through how to navigate and maneuver them. And what's funny is some of the kind of archaic voice systems that we have, you can still make work reasonably by macros. So Dragon, the dictation system from forever years ago, you can just program it things to do actions based on the things that you're saying. A lot of kind of historic voice tech works the same way. The issue was that it was lacking a lot of the flexibility in the way that humans would naturally discourse. You had to say it the exact same way every single time, otherwise it would fail and become frustrating. So you were teaching yourself to talk to the computer versus the computer learning to adapt to you, which is, I think, where we are now and what's different now. Right now, a lot of folks are really excited and adopting some ambient workflows where you can have a natural conversation with a patient and then say the things you need, and then the note is magically generated. Well, my dentist, years and years and years ago, before any of this, I think he was using just a regular voice dictation macro system where he'd be like, tooth number 31, cavities or something, and it would just like magically go in there because you know what, his hands were a little tied up. So the technology in some form has existed for a while, but where we are now, where an everyday person can say words and instantiate it almost like you're Harry Potter and just have things happen, is what's different and what's exciting. What people are starting to notice beyond just
Hmm.
us nerds have been excited about it.
Feels like the Turing test is finally being passed.
Yes, amen.
Close,
Okay.
so close. So I think obviously, if you're excited about voice tech, and you kind of alluded to it in terms of, you know, computers understanding natural language now. So we're just going to flow right into the AI discussion. As far as AI being integrated into healthcare IT, like what tools do you think are going to help? Because we talk about augmenting clinical decision making versus making clinical decisions. Like, what tools do you think, or do you foresee, are helping in that respect?
Oh boy, where to start? Well, so I think thinking through what tools are going to make the biggest impact, it really starts with outlining what it is we do in
Hmm.
healthcare
Hmm.
and what a doctor's job is versus what a nurse's job is versus the administrators of the hospital, and thinking through like the different steps of what they do, from when they wake up in the morning to when they sign their last note, at 11 p.m., and which parts could be facilitated with these tools. The hope is that this can help us get some of the drudgery, the pain out of the work we're doing and introduce more of the satisfaction in the care that we're delivering. So I can speak from a physician's perspective that a good amount of the work that we do outside of seeing patients, which is most people think about when you talk about your doctor, because that's where you see your doctor, but it's just like paperwork. It's writing notes, it's reviewing charts, it's looking at messages in the baskets that come through and different tasks. And I would say that's the majority of the work I do outside of the delight and the fun, the joy I get from seeing my pediatric patients and the little like 3-year-olds running around the room trying to unplug the computer as I'm using it. um, and if there are tools in place that can help with some of that, man, that would be so satisfying. So you mentioned like diagnosis and care planning and things like that. I think that area is super fascinating because all the benchmarks that are coming out showing how well these tools are doing at figuring out really nuanced, intricate diagnoses that some physicians even miss, and scoring really high on benchmark tests to demonstrate competence is really cool and fascinating. When you've been doing the kind of work that I do in pediatric endocrinology, you're doing it for a long enough time, a lot of things you see are kind of bread and butter. It's like I know how to manage congenital hypothyroidism. I know how to manage adrenal insufficiency, and it's not really a medical mystery. But every now and then there's a patient that has you saying, "You did not read the textbook." And I would love for some other eyes on this and other consultants, just to look at the data to see, is there anything else I'm missing? I'd love for someone who's read every single journal article in PubMed to weigh in. And that's pretty exciting to
Mhm.
think of some of those aspects of being able to tap into another resource that has just a wealth of knowledge beyond what any person's able to retain at once, and help to add or augment the diagnosis or differential we're coming to, just to help patients get to their answers faster. And then just the routine, mundane tasks like writing notes and trying to find information in the jungle that is the EHR.
Speaking of the jungle that is the EHR, I'm just going back to what you said earlier about when you started using the EHR. And I started off answering help desk phone calls. So I appreciate that it sounds like, Dr. Ya, you are one of the friendly end users on the other end. And speaking of friendly, so yeah, you have been involved in making Epic more user friendly for clinicians. And so yeah, what are some key innovations or strategies that have had the biggest impact on usability in Epic?
One of the things I think is really promising, it's still very early, but chart search. So, okay, I don't know about you, but on my Mac, my folder organization, not great. My desktop is just a disaster, and it's embarrassing when I share my screen. I'm like, don't look at that, don't judge me. So finding anything can be a bit of a challenge. And like, I know exactly the thing I'm looking for, and I want to figure out where it is, but it's somewhere in here, and I have to figure out, is it my documents or my desktop or my downloads, and what the file is called, how did I name it? Was I using good naming convention that day when I was trying to find it? That is not unsimilar to trying to find information in the EHR, where everything is it's chronologically based, but based on the different times people are saving notes to a particular encounter. You're like, oh my God, what did that person say about this thing? I just want to know what their history was, where their trajectory was with their asthma, with their ear infections. How many infections have they had? And just simple questions. You can define exactly where your question is. And you're like, man, I could probably write a SQL query to answer this thing, but there's no easy way to just grab that piece of information from the EHR because of how it's organized. And to be able to get to a place where you can just search the chart, just say, what is this thing? And for it to tell you back that information in an accurate and a way that matches what is actually the known truth would be amazing. Because A lot of the times when you're trying to put together the story for the day, you're seeing your patient for their clinic visit, and you're just trying to get caught up because you haven't seen them in 6 months, because you see them in 6 month intervals. You're like, well, what happened since I last saw them? And they might have had some ED visits. They might have had a hospitalization. They might have seen some specialties. And you're like trying to put the pieces all together. That might be like 20, 30, 80 notes that you have to read. And it's just unreasonable for someone to be able to put those all together. And you know what LMs are great at? Summarization. So if you can just say, hey, grab these notes for me through this interval and then summarize for me the key things that happened since I last saw the patient, and to get those insights generated for you as bullet points that you can like say, oh, okay, well, that sounds interesting. Let me dig into that more. Um, is so helpful and can save so much time, and also surface some things that you might have otherwise just not have had an opportunity to click on because there are 80 different things to click on. At the same time, always have to add the caveat that it's interesting to understand what it chooses to prioritize, so that you can know what it might leave out for whatever reason, for whatever some training data, whatever biases it has, so that you can know back to fill in those gaps yourself.
I love your enthusiasm, and you can really just tell how excited you are. Sometimes we're always working our best to help people see the benefits of technology, which you kind of already see. But at the same time, I'm sure you see the limitations. You see where where we need to find that balance. When I think about the integration of AI systems, or improving the use of an EMR or EHR, like what's that line for you when it comes to interaction?
Oh, great point with regards to the patient facing side of things and what their experience is. With some of the new tools that we're using, like tools that can record a conversation to write a note, that's great. That's super efficient for the physician. And it's useful for the patient also because they can see a summary of the note on their side. But some people have apprehensions about being recorded, and understanding how their data is going to be stored and used. I think there is still a lot of discourse that needs to be had to socialize and normalize this
Mhm.
in terms of how we're going to be delivering care, and making sure that we don't lose sight of like what is the problem we're trying to solve. The point of this all, hopefully, is to remove the technology, to remove the considerations of the intrusiveness of the technology,
Mhm.
so that we have more time to be with the patients, to answer their questions, to understand them. So we had, a whole enthusiasm about digital front doors
Mhm.
several years back, where, we'd have the patients and they'd be able to have things that they could chat with to get information, so on and so forth. And like sometimes you're like, I just want to talk to a person. I'm feeling miserable. My head hurts. I'm in pain. Like I think only another person could understand that. And I think the more we're able to remove folks from the drudgery of all the other stuff that takes away time, the more we can place them in front of and with their patients so they can answer those questions. And sometimes you kind of just want to get an answer, a quick answer. What I'm really curious about is how we can allow patients to surface information just as easily as you're able to with some of these LMs,
Mhm.
to make sure that they have a bit more validity to them than just any own LM out there. And what organizations can do to maybe train certain LMs to be more specific to the issues that a specific patient has encountered. So it's more personalized, so that it can have the context of like your medications, your allergies, your past encounter, so that when you ask a question about like, how will this medication impact what I'm doing, it can pull forth from that and give information that's more contextual. And I don't think we're at the point yet where it can directly be surfaced to the patient.
Mhm.
So the provider can review it, vet it, and have some information that's more personalized for the patient. I'm hoping the point of all of this is so we can be more present, be more human,
Yeah.
versus just adding another layer of automation to things that don't work well.
Yeah, absolutely. No, better patient onboarding, or at least helping them understand the role that, whether it's their own self-management portal or their instant messaging, like helping them understand how that helps them get to spend more quality time with their physician. I think, yeah, that's a great idea.
A cool thing I was just in a conversation about the other day was the patient messaging workflow, where oftentimes patients will send a message to a provider asking about a concern or issue they have, but there isn't necessarily enough context behind the message. They'll just say, like, oh, I'm having headaches. Can you write me something? Or my whatever's flaring up. Can you help me relieve this issue?
Hmm.
But the provider might have more questions that can help them give a better answer, like, well, how long has this been going on? What have you tried? So on and so forth. And then there can be back and forth with that conversation that takes longer time for the patient to get their answer.
Hmm.
So one of my colleagues, Adam Wright, has been working on an application that when a patient is drafting a message to say, like, hey, doctor, this is a concern that I have, it will review the message and say, that's a great message, and sorry that this issue is occurring. Here are, three other questions your doctor might need to know
Hmm.
to help them better answer your question, and can help walk the patients through thinking through, like, here's how to write a more complete message for your doctor, and then package that up to send it to the doctor so they have all the information they need, so that hopefully in one shot they can provide an answer to the patient versus having to go back and forth. And what's neat about this idea is that it's not doing anything risky like giving medical advice or anything like that. It's just saying, like, how can I help you draft a better message? How can I help you make a more complete question? And that's a really interesting idea that I'm going to be interested to see how it materializes.
So wait a minute. Like right now, 2024, 2025, like a rising job that's kind of out there is prompt engineering, but but
Hmm.
but he came up with software to basically doctor. It's like engineering. It's prompt engineering, so that you can actually prompt your doctor and give your doctor more complete information. So
There
we've already
you
come full
go.
circle. That's amazing.
I love it. I'm going to have to take that back
Yeah,
to him.
please
That's so
do.
ironic. I hadn't thought of
That's
it like that.
awesome. Yeah, yeah. Learn how to speak to your doctor.
It's so interesting because I remember reading The End of Illness by, I think, Dr. David Agus, who was part of Steve Jobs' care team, and it was such like a simple but mind blowing message within the book about how to be a good patient. You have to, come to the provider with specific questions about your health to help the provider figure out, how to help you. It's like the cube of good, like help me help you. And you're talking about, sort of the Overton window around adoption, and it seems to me like this is, yeah, I guess what I'm kind of assuming you're curious on this, because it seems like this is a way for LLMs to slowly work their way in, and then for those patients that are like, not my data, not my, you can say, well, hey, remember that workflow you did? That was, you were working with an LLM there, and so now we're just taking it a step further. I don't know if you see that adoption curve like that, but that's sort of how it played out in my mind as you kind of told that example.
I think so. And one of the joys I have as a pediatrician is my patient population is obviously very young, but that means their parents are generally on the younger side of things too. So when it comes to technology adoption, I don't think we have as many challenges as some of my internal medicine colleagues when it came to telehealth and things like that. They already had all these apps on their phones. Very often they're teaching me new things. I do agree that even with some of this technology, people are getting more and more exposed to it. And at some point, it's unavoidable. I think right now, even on Google, like by default, you're going to have an AI summary, whether you like it or not. So I think as people get more versed and more immersed in it, hopefully this means that people have a better understanding of its strengths and weaknesses, but also how it might be able to actually help them in their daily work.
So we're talking about, obviously the incredible things that healthcare technology can do to improve patient care, to improve access to their care providers. But we have to acknowledge that there are those who don't necessarily have equal access to healthcare technology. I mean, a general question would be, how can organizations ensure that these innovations are available to all patients? And then maybe a follow up to that would be, is Vanderbilt doing anything specifically to address that?
And that's a really, really important question, and something that we've seen a lot of just over the years, going back to telehealth in and of itself, making sure that as these new technologies become the mainstay, we're not widening the gap between the haves and the have-nots. What's interesting about the way some of these tools are being introduced is there's not a really high barrier to be able to take advantage of them. For the patient facing side of things, for the EHRs, I don't think we have as many of those in place right now, just because I think health organizations are still a bit reluctant to go full in on transformers and LLMs given some of the risks with hallucinations. But at the previously mentioned helping a patient draft a message that can help them communicate more effectively with their provider, that's something that can be available to just about anyone that has a patient portal. But then that means that's that person that would have to have a phone, a smartphone. And what does that mean with regards to gaps in access for these tools? But with these tools, and most of them that are able to just either run on device or run with a really low load, WhatsApp is a very popular application that's used across many countries outside of the US. And Zuckerberg built in, the Meta AI in there. So even, wherever you are in the world, if you have access to WhatsApp, which is a lot more people than you'd imagine, they have access to these AI tools and these LLMs. So I think accessing them, just because the tech companies are so enthusiastic about getting people on board, it's actually a really low threshold. My main concern is just educating folks on what to expect with them and how to appropriately use them. And I just would love for there to be more of a focus on making sure that the information, the way people are asking information from these tools, is going to reflect the quality of the information they get back. I don't think a user should, or a patient at least, should have to be a prompt engineer to get a good answer out of the LLM.
Right.
But really, they'll answer the question that you gave them. So if you ask a question that might not be as robust, if you say like, oh, I have a really terrible headache and I don't want to see a doctor, give me good reasons why I shouldn't see a doctor, it will give you good reasons to not see a doctor. That's what you asked it.
Absolutely.
But I would hope that, higher level, if we could think through, well, what's the prompt behind the prompt, and what's the actual thing, what's the goal of the LLM? It would say, well, my goal is to make sure this person is safe and healthy. And it could see beyond just the question that's being asked to phrase something back. And I think if we can put resources in place to ensure that there are tools available, open source, for people to take advantage of that have a focus on health, then we could hopefully ease some of those gaps with parity.
So I have two follow-up questions. First one, feel free not to answer. Are you partial to any LLM above others? Perplexity, OpenAI, any one that you prefer?
I would have to say I am a very LLM promiscuous. I will
Okay,
use
that's fair.
any and every, and I often pit them against each other. Just the other day, actually, this was really fascinating, to me at least. I'm going to be going to a conference, and I'm flying into an area, but then the final destination is a bit further away, so I would have to take a bus route to get to this location. And the bus had like certain drop-off points, and I was like, well, which of these drop off points is going to be the closest to my final destination? I'll even send this to you if I can. And
Yeah.
I tried all of them to say, like, which one's going to give me the best answer. And I was interested and delighted to find that it was actually Google Gemini that gave me the best answer,
Oh,
because they gave me a map also. And I'm the first to dunk on Google and how slow they've been with all their implementations. But I do this all of the time, with regards to trying to figure out which of these tools are best for answering which kinds of questions. Because that's just the thing. They're all different at different things.
Mhm.
So Claude, I think, is lauded for being good at coding and things like that, because I think that's one of their main focus. I love the OpenAI models because of their voice tools. I mean, they've spent a lot of energy and focus in making sure those are really robust, and they have APIs for some of these tools that you can work with voice user interfaces. And some of the other provider don't have as much interest in that. I think I don't want to dunk on any of them, so
sure.
maybe I'll leave it there. But I'll send you that one, because that was a fun one to do. But I will never ask just one tool. Perplexity is very interesting because it searches the web and will do kind of a more thorough web review of information for you.
Yeah.
From a provider perspective, open evidence I find has been really interesting also, just because it has access to some of these journals and medical information, actual like references that you'd want to be paying attention to. So, and one of the cool things that OpenAI came out with first, and everybody else is duplicated because there's quote unquote no moat anymore for any of these things, is deep research, where it'll go out and scour the web and do kind of a very thorough analysis of your question versus just a regular chat query. And it was cool. It still is cool. It's neat. But what was missing is, like, when you'd ask it a question, it didn't have access to PubMed. It didn't have access to all the good journals and Google Scholar or anything behind, a paywall,
Mm.
for good reasons, licensing, copyright, etc. But to do scientific research, that's what you need. So
Right.
I'm going to be interested to find out what the next generation of these tools are going to look like that can actually delve into some of the content sources that are actually going to be needed to solve some of these more tricky questions.
It seems like hallucinations are kind of a big issue with law, med, and curious to how you see us solving that, or maybe we don't, and maybe because hallucinations are some of the beauty of AI and some of what makes it so great, and we have to figure out, because like the creative, it is amazing when you have, it's like, wow, I typed this in and it created this work, that feels human, but again, that we can't have that when you're asking for a fact in medicine.
Right.
Super excellent point. Because I mean, depending on the problem you're trying to solve, hallucinations are actually going to be the premise of coming up with something really fascinating, or the downfall if you're trying to
Right.
medically manage someone.
Right.
What's interesting though, and this is something I'm still trying to reconcile with regards to all the approaches that we're taking so far, is that in medicine, there are conditions that are very kind of like pathognomonic, and we have rubrics and methods and algorithms for managing like 99.9% of everything that already exists. Like, we have
Mm,
textbooks that were
yeah.
taught in school on how to do these things. And there's this concept called RAG, where you just like read this thing and answer it based on this thing. And that
Right.
greatly reduces hallucinations. And I'm like, I feel like, at least in medicine, this is less of an issue, um, if you're just not basing it simply on what the base model knows, and if you're
Mm,
using just some known sources and pointing to those things. Also, with other techniques that they're using, like test time compute, where you just like make the model think longer. So, an example that happened like really early on with some of the
mm,
models is like, you'd ask it a question, and then it'd give you maybe a wrong answer. It'd statistically pull up something that made sense but wasn't the right thing. And then you'd say, like, well, try again. And then it would do better. I'm like, well, what if the tool prompted itself to try again three
Mm.
or four times before turning out the right answer? And that's essentially what it's doing with the chain of thought reasoning and some of these other. Well, I didn't even mention DeepSeek.
yeah.
So, so I think we're getting closer and closer to there. And
Yeah.
with hallucinations, with medicine, and what we're trying to accomplish, with diagnosing the super rare diseases, etc. I'm always curious to wonder how much we as humans ourselves, quote unquote, hallucinate and
Sure.
make stuff up and make false probability matchings when we come up with stuff. And I'm like, at what point is it just going to be acceptable that these tools aren't perfect, but still better than some
Sure.
of the errors that we are causing? Because
Mm.
I don't think it's reasonable to expect it to be completely flawless. But I think at some point we need to compare apples and apples and say, well, I think maybe it's still doing a pretty good job. And I think at some point it's going to be maybe even unrealistic and considered unsafe to not incorporate some of these things in decision making.
Hmm.
Sure. Now, we all know that Vanderbilt is obviously the greatest university in the world, and where I spent some of my formative years. But another school that I spent some time at, and that we have a lot of ties at HTM, is Stanford, and they have developed, or Stanford Healthcare has developed their own LLMs. Are you all doing that at the UMC?
Oh, indeed. They are doing some really, really amazing work at Stanford. And I have a lot of really cool colleagues there that I learned so much from. But yes, Vanderbilt is definitely boots in the ground, evaluating how to build and augment and develop some of its own LLMs and just the best strategies. I think whenever you have informaticists in a room, you're going to want to build something cool. But the bigger question about build versus buy really comes into play as some of these models get more and more sophisticated. And from a kind of engineering perspective and thinking through like what the best strategy is, like, well, what's the end goal and what's the least expensive lazy way to get there? I think a good engineer always wants to maximize laziness and minimize the amount of effort to accomplish a goal. And what is the benefit in like what when you're building out something, what are you uniquely providing that something else doesn't, that makes it worth the effort to do that versus taking something that exists and building on top of that. Some of that is still to be answered. And some of these you can only answer after you're like, well, let's try to build it. And like, wow, that was expensive. And no, our results aren't as good. But once we start getting enough data around this, I think it'll kind of converge on what the most realistic approaches are. But yeah, we have a lot of interesting models that we try to build and train. Some of them are working really well for very specific use cases, but again, like I'm waiting on GPT-5. Like, certainly don't have the investments that OpenAI does, so I wouldn't even try to compete with something like that.
Our final question is basically, as a leader in health IT, what advice do you have for organizations looking to drive innovation while keeping that strong clinical focus?
I would say that the key thing is to understand the workflow. Just map it out. Just say like, what is the day in the life of a nurse? What are they doing? What are their pain points? And what are the low-hanging fruit things that really they would be more than happy for an AI to take their job doing that? Like entering flow sheet rows, for God's sakes. Or I think any nurse would be like, please won't an AI please take my job when it comes to entering flow sheets so that I can actually be with my patient and talk to them about what's going on. And then just explore the different tools to understand what's going on. And I think as leaders in the healthcare space, I think we need to come together to establish kind of like best practices and benchmarks so we can reasonably compare some of these tools. Because literally everything has like AI augmented, AI enhanced a sticker on it now. I can't blame anyone for working to stay competitive, but how do you reasonably compare product A against product B? And I think looking through the landscape of things and having some kind of like understanding and benchmarking methodology would be helpful to each other.
Thanks again for listening to Quick Hits, a healthcare technology podcast for healthcare technology professionals. Follow us on Spotify or Apple Podcasts, and don't forget to reach out to us with feedback, suggestions, or even people in the healthcare technology industry you think we should interview. Send an email to quickhits@healthdatamovers.com.